Good evening. Hello to all ODA members who've joined us tonight. It is my pleasure to welcome you to our webinar on the economic perspective of the Canadian Dental Care Plan, an analysis by House Economica. My name is Marcus Davis, and I'm the ODA's Chief Communications and Events Officer. I will be your moderator this evening. I'll introduce our speakers shortly, but before I do so, I'd just like to provide a few notes about today's webinar. Today's session will run for about 90 minutes, and we will be providing a recording of this presentation, which will be made available in the coming days. The presentation you're about to watch was pre-recorded within the last week, and the information being presented is current as of that recording. Following the presentation, we will move into our live question and answer portion. For those of you who are watching the recording of this session is being recorded on the evening of June the 4th, 2024. Today's presentation is on the economics of the CDCP and is delivered by independent consultants to the ODA. The presentation does not cover the ODA's work on advocacy, and our presenters will be unable to answer questions about the status of the government's work on the CDCP. Those questions may be answered at a future ODA opportunity. So for those of you who are attending the live session, you can submit your questions through an Ask the Question box, and this is located just on the top right. If you look at the video where you can see me, just to the top right, you'll see a little box and it says Ask a Question. So if you're not able to see that, you might be in full screen mode. To view and access that box, what you need to do is exit the full screen, and you can do that by hitting the Escape key on your keyboard at any time. If you need technical help, please click the Help Desk button. That's the box that you'll see just to the right of the screen, just below the Ask a Question box. And again, you'll need to exit your full screen mode to be able to do that. Just click the Escape key. If you're watching the recording of the webinar, you can email any questions about today's presentation that you might have to the ODA directly. And at the end of the presentation, I'll share those email addresses with you that you can use. The opinions that are going to be expressed in today's webinar are those of the presenters. The opinions do not reflect those of the Ontario Dental Association, its volunteers, or its staff. Nothing in today's presentation should be regarded as advice on any subject. Viewers should consult their own advisors prior to making their own independent decisions. And now I would like to welcome and introduce our speakers. With us today is Dr. Ron House, the founder and chief economist of House Economica. There, he leads a team of highly qualified economists. Dr. House has over 4 decades of experience providing consulting services to organized professions, primarily dentistry and medicine. His expertise has been sought by private industry, government departments and ministries, boards, commissions, standing committees of provincial legislatures, and the House of Commons. He has also provided written reports and expert testimony in numerous legal proceedings. Dr. House was a faculty member at the Department of Economics at York University for 37 years, specializing in microeconomic theory, health economics, and finance. He has also held positions at Johns Hopkins and McMaster University. Our second presenter is Mr. Graeme Reid, president and principal economist at House Economica. Mr. Reid holds a master's degree in economics from Carleton University. He worked as an economic consultant with House Economica, which is formerly RK House & Associates, starting in 2015, gaining a wealth of experience in statistical analysis of survey data and market demand forecasting. He focuses on providing clients with clear, sensible recommendations based on economic research and market conditions. Thank you to both of you for giving us your time and your expertise tonight. We'll start the presentation with Dr. House, who will share his personal perspectives on the economics of the CDCP. Dr. House.
Good evening. I've been asked to talk a little bit about the CDCP, and I have to start with a disclaimer because I don't know a lot about it. All I know is what I see in the press. I haven't been privy to any of the discussions, and so I don't know what's transpired between the minister and the profession. And so I have no insight into that kind of thing. What I want to talk about is the level of fees, the implications that they have, and what we might expect next year. As you all know, the minister at this point has said that the profession can balance bill to your usual and customary fees. And for the majority of dentists in Ontario, that means that they would be billing to the suggested fee guide. And so in looking at that, what we're going to see is an expansion of demand, as you might imagine, because we're going to see a lot of new patients. Your practices will be busier, and you will see a rise in income. Everything will look very rosy, but I have to say that one of my concerns is that this whole plan was cobbled together not to meet a dental need, of course, but to satisfy a political need, and things can change. We are in a state of flux. As you all know, we have no permanent agreement. So one of the concerns that I have is whether or not we're really in a situation where this is bait and switch. Having said that, I think that we have to recognize that at this point, getting the right to balance bill is a great victory, and something that the profession should be extremely proud of. The question is going to be whether or not in the future we can hang on to that concession from government. There are some things that are rather strange about the CDC proposal, and I would like to take a look at the fees. So could I have the next slide, please? Yes, and the next slide after this, please. What I want to draw your attention to is the level of fees overall. As you can see, they're nearly 84%. But when you parse this down to the bits and pieces, what you'll see is that preventive is paid at 96%, restorative at 82%, and oral surgery at 80%. I find that passing strange because the population that the profession is going to be invited to deal with is going to be a population that is in need of restorative care. I would have thought that the appropriate response of government might well have been to put the emphasis on restorative and oral surgery, because this is what people are really going to need. In fact, I would go one step further and say that I think that they're misguided in providing such high fees for prevention, because I think if you were to test the efficacy in economic terms, not in clinical terms, but in economic terms, of preventive for this group, you might come to the conclusion that they would fail any reasonable benefit cost test. And the reason why I say that is that periodic scaling is really only effective if it's backed up by good home care. And this is a population which previous studies have shown generally are not as assiduous in dealing with home care in the way they should, and instructing their children to practice good oral health at home. So this is one of the mysteries that I see in this whole thing. And it's also curious that we see that orthodontics is paid at a very high level. Again, there's going to be questions about whether or not these things get used to the extent that we might imagine, or whether the emphasis in the clinical sense is going to have to be on restorative and oral surgery. Could I have the next slide, please? This is what I think we're facing right now. The numbers here are interesting. In Ontario, the average patient spends about $750, this is patients that come to the dentist, spend on average about $750 a year. And so I want to look at that patient if they were to come in and they were to be billed under the CDCP fees. And what you can see is that under the CDCP fees, they would actually be billed $638. Now, I want to look at the consequences of that, because that reduction in your gross revenue does not lead to a reduction in your costs. And at a 60% expense to gross ratio, your cost on that patient would be $450. So what you can see in the little box, net income, is 750 minus 450 gives you a net income of $300. The same arithmetic, subtracting the $450 from our $638, gives you a net income of $188. Now, this slide also proves one further fact, and that is I'm human, and there's a mistake on the slide. The income loss is indeed $112. Percentage loss is what is wrong. I've put 112 over 450, which is the expenses. I should have put the 112 over $300 And there you would have seen that you would have had a net income loss of 37%. Now, I don't imagine that there is anyone that will tolerate a 37% reduction in their net income. And the only way you can make yourself whole on an hourly basis, of course, is to balance bill. So what you're going to hear me say again and again is that you have to balance bill. This is what a better breakdown so we can see exactly what's happening and the differences here. This is patient reimbursement for somebody earning under 70K. These people will not be expected to pay a copay. And so you can see that I've broken down the $750 to $450 of remedial care, about $300 of hygiene care. And under the plan for the dental, the plan will pay about $360, and you would be required to make yourself whole to balance bill a further $90. Under hygiene, you're going to get the 95% or 96%, and you would have to balance bill another $15. So the total payment that would be made to the pay or required of the patient would be the $105. Now, I want to just pause for a minute and think about this, because what I'm doing is I'm comparing these patients with the typical patient that comes into your office on a regular basis. And of course, this is not an apples to apples comparison. We are looking at a population that is probably suffering in many cases from years of neglect. So instead of having an annual need of $750, we might double that and say they have an annual need more in the order of $1,500. That's perfectly reasonable. Now, I want to now go over and look at that $105 again, which is what the patient would have to pay on this calculation, and recognize that if the patient really did require $1,500 worth, they would now have to make a payment of about $200. I want you to think about one thing further. We're talking about families here. This would mean that a family of four could conceivably have to pay up to $1,000 for their care. And $1,000 for a family that's maybe got a family income of $40,000 is a big bite. What I'm going to suggest is that in the long run, this may not be a very stable situation, and we can't imagine that government would be responsive to protests on the part of patients who they believe are going to get their care for free. And that, of course, is not the case. The other thing I want to look at in the smaller box here is what the incentive will be for these people if they did have third-party insurance, because the question about the erosion of third-party insurance is a major one throughout this whole plan. And what you can imagine here is that when we've taken a broad look at private plans, there's about a 20% copay requirement one way or the other. More in some cases, annual limits that are bumped into and all the rest of it. But what I want to do is give you a sense of what might happen. Under the plan, this patient might pay as little as $105. Under their third-party plan, however, they may have to pay $150. Therefore, there would be a strong incentive for people under 70K that have no copay to switch from the third-party insurance to the CDCP. Next slide, please. I'm now looking at those between 70 and 80K. And here the story is a little different. Let's just jump to the final results. If you look at what the patient has to pay now, it's the sum of the copay and the balance billing. Because if you're in that 70 to 80K range, you're the first group that bumps into the need for a copay. And so if we add together the copay and the balance billing, here's a situation where the patient would be expected to pay $363 for their care if their care totaled up to $750. And now going down to the lower box, what we see here is that under their third-party insurance, the same patient may only have to pay a copay of $150, that 20% that they don't get reimbursed by their plan. And therefore, they have a strong incentive to stay with the third-party plan. This is a good thing. In other words, whether this is intentional or not, the government has built into the CDCP a reason for people above the 70K rather, to stay with their dental plans. But what I want to draw your attention to is that under this situation, the patient is paying almost 50% of the total cost of their bill. Again, a long way from the notion that this is a free program. And we can imagine that there are people that are on the cusp of that $70,000 to $80,000 thing with incomes of 71 or 72,000 that suddenly find themselves stuck with, and again, imagine this is a family of four, didn't have a dental plan, and you can take that $300, imagine it's $500 because they're without continuous care, family of four, we're looking at a couple of $1,000s. This is a significant part of the income of families at that level. Next slide, please. Well, the story just gets worse. If you're in the 80 to 90 bracket, of course, you have to pay, you have a copay of about 60%. And here what you can see is the patient pays $492 of their $750 that we're going to collect. And that's 66% of the total payment. And here we can jump to the conclusion, obviously, for these people, there's a very powerful incentive to stay within their plan. But if they didn't have a plan, the idea that our family of four could wind up with, again, a $3,000 bill for their remedial care, again, this is going to be a touchy issue going forward. Next slide, please. Here are the things that I would like to emphasize right now. And the only way to preserve your hourly income is to balance bill. Now, I'm going to make a distinction between what I'm saying here, preserve your hourly income, because you will find at least about 30 or 40% of the profession will find that their incomes rise simply because they're able to fill idle time within their practices. There are a substantial number of practices in Ontario that would like to have more patients. And just having more patients, even at the CDC level, is going to be very beneficial. The other thing that we have to remember is that right now it appears that those that are on the provincial plans will migrate to the CDCP, and that is going to lead to a substantial income, but a substantial improvement in income for some practices. But I would warn you that your hourly income is what's going to suffer. You are all going to wind up probably working 20% more in order to preserve your incomes if you do not balance bill. The other thing about balance billing is that, remember, government is going to be watching what happens. And like any plan administrator, if they see that the majority of dentists don't bother balance billing, they're probably going to come to the conclusion that balance billing is not necessary. And therefore, I think that the conclusion they would reach is that the CDCPs are perfectly adequate. My view is that they are not. You will all suffer a significant decline in income if you do not balance bill. And so then my third point is that if you don't balance bill, the right may be taken away. So even if you enter into the plan initially with very altruistic motives, and then the bite comes, and you'll see that it's going to come in a variety of ways, I think you want to protect the right that you have now. And I think it's important that government understand that the reason, in my view, the principal reason why the profession is cooperating with government at this stage is because they have the right to balance bill. And lastly, I want to point out, it really doesn't matter what the CDCP fees are if you balance bill. Now, I have a caveat about that, and that is that the CDCP fees could be too high from my point of view. For example, imagine that the CDCP fees were, let's say, 95% of the current fee guide. A lot of you might come to the conclusion that it's not worth the hassle to try and balance bill. Well, if you give up 15% or sorry, if you give up 5% on your total revenue, what that's going to do is reduce your net income by 15% if you have an expense to gross ratio of 0.6. So don't make the mistake of thinking that the reduction in your fees or revenues is the same as the reduction in your net income. It's not. Your net income suffers from a much greater decline. Could I have the next slide, please? And the next slide after that one. I'm now going to argue that there are situations where I think people have no choice but to balance bill. And my first example here is what I've called the associate problem. What I'd like you to look at here is we've modeled a typical associate working 1,200 hours a year, grossing $360,000 a year with a net of $144,000, and the principal recovers $216,000 to cover their expenses. That would be a typical associate contract at work. Now let's take a look at what happens if they only bill the CDCPs. That $300 gets knocked down to about $240. The associate's net falls to $96. The cost recovery on those fees would only be $144, still working the same number of hours. That, of course, could change, and so that there might appear to be an improvement. But remember, generally speaking, as hours increase, the gross expenses are also going to increase along with it. It's a linear function. So here's what happens. If only the CDCPs were charged, the associate would suffer a loss of $28,000 in net income. And their net income would fall to $115,000. Now, I have to tell you that we've got associates that are already earning under $100,000, and a decline in their net income of this magnitude just is not sustainable. But what is really interesting is that look what happens to the principal. All of a sudden, there are $43,000 in expenses that the principal's incurred that aren't being covered. That $43,000 comes right off the principal's net income. So if you're a principal with an associate, you cannot tolerate just saying, okay, we're going to charge the CDCP fees. That to me is not an option. What some principals might think is appropriate would be, well, I'm now going to insist that I get my full cost recovery. And if we run through this, you'll see that over on the right-hand side, that the principal recovers all the costs. Now what happens is the full burden of the adjustment falls on the associate, and the associate's net income is reduced from $144,000 down to $72,000. It's cut exactly in half, and that is not a tolerable situation. So I don't think that any practice that has an associate really has much of a choice here. I think that because existing contracts sometimes have limits on reopening and that kind of thing, that if you have an associate thing or associate in your practice, I think the thing is that you've simply got to decide here now, you're going to charge your full fees and balance bill to that extent. My next example, next slide, please. My next example is the impact on corporate dentistry. We don't have really good figures on just how extensive corporate dentistry is in Ontario, but it's growing and it's a concern. And the only real insight we have is from Dental Corp, because it's a publicly traded company. And it's interesting to see what Dental Corp has done. Now, the interesting thing about it is that if you are familiar with the typical Dental Corp contract, the dentist generally gets reimbursed at about 60% of their own production. They do not participate in the production of the hygiene department. Now let's take a look at, so I better draw the obvious conclusion here. Dental Corp depends upon the hygiene revenues. And what you can see here is that since its inception, the initial public offering, the share price for Oeconomicae has fallen by 54%. Some of you may know that I taught finance, and I will make a general prediction now that I don't think this decline is over. I think it could continue. Next slide. You can see that revenues and earnings, there has only been one quarter in the history of Dental Corp where they've shown a profit. And my comment here is really a very simple one, and that is that Dental Corp could not afford not to balance bill. So just the competitive pressures on the corporate dentistry with the typical kind of contracts that have been written are going to require them, I believe, to balance bill. I don't think there is a way out of it. If they didn't, I think what we can predict is that that stock price is going to decline even more rapidly. So here again, I think we've got two major forces. All those people that are involved in corporate dentistry are going to have to seriously think about balanced billing. And for 50% of, nearly 50% of the profession, which are now associates, their only salvation, because they do not participate in the hygiene revenues and because the dental fees are so low, they can only make themselves whole by balanced billing. Next slide, please. Now, at the beginning, I mentioned that hygiene was paid at 96%, and I found that very, very strange. What you're seeing this evening is part of a presentation that was made earlier, and at that time, what I did say was that, as I've said here, that it has the lowest probably benefit cost ratio of any section of the fee guide. And the only rational explanation that I could come up with was that government tended to promote independent hygiene. And since I made this slide, the ODHA has written the minister and said it is unfair for there to be two fees for the same procedure. And I think probably there would be very broad agreement within the public that, yeah, if it's the same procedure, it should have the same fee. Now, I'm going to guess that, and the minister in response, I believe, has said that he would take it under advisement, but also said that he thought that it seemed to be inappropriate. I'm going to guess that what happens here is that instead of the fees for dentists being lowered to those for the hygienist, we're going to see the hygienist fees be raised, and that will mean that the hygienists are going to actually see their CDCP fees in a few cases being higher than in their own suggested fee guide. Now, I worry about this because I don't believe that it is in the interest of the public or very broadly dental care for there to be a fractioning of the delivery system between independent hygiene and dental practices. And the reason for that is that in all the studies that have been done in medicine, there is very clear evidence that the more appointments a person has to make in order to get care, in other words, going to a GP, then do maybe an X-ray, and then maybe a specialist, that kind of thing, that they just get weary and sometimes fall off the wagon and don't complete their appointments. And of course, this is not good for their health. And I can imagine that if someone was told that, well, this year you're going to go to the hygienist a couple of times and to the dentist once or twice, people are going to be reluctant to do that, and we're liable to see them less frequently in the dental office. And that, I think, is probably not a good thing for their health. So generally speaking, I would oppose the idea of independent hygiene practices. Having said that, there are those that believe that independent hygiene practices are a solution to a perceived problem, not necessarily a real problem, but a perceived problem. And the perceived problem is that dentists sometimes do unnecessary procedures. Not very much evidence of that actually happening, apart from a couple of CBC interviews and a few things like that. But what they're really saying is that maybe hygienists should become the gatekeepers for dentistry and control the level of remedial care. Again, I think this would be a very bad thing, but if this is something that government has paid attention to, this may be an explanation of why they're going to support independent hygiene. Now, the evidence over the last 20 years really is that independent hygiene is not a viable way of delivering care. It's not much, there's very little cost savings. From a societal point of view, there is a duplication of equipment and so forth. So it's really not, from a very broad perspective, a very efficient way of delivering care. Nevertheless, the appeal that there could be this kind of competition or gatekeeper control over dentistry may be appealing. So this is something I think we need to worry about. Could I have the next slide, please? Just to recap then, we want to reduce the third-party erosion, because I think one of the principal policy issues going forward is to try and preserve as much of the delivery system as we have, and that means a high level of dependence upon third-party dental plans. And what I would say is always balance bill and make patients aware of the fact that you are balance billing under the CDCP. Make patients aware of what they would pay under the CDCP. For those above the 70,000 and above 80,000, you can see that as I pointed out in the slides, that the amount that they would have to pay out of pocket would be much greater than if they stay with their third-party dental plans. And the third point, the ODA guide has over 1,200 procedures in it. And granted, there's a lot of those procedures that are not reused or very seldom used. But the CDCP only covers about 400 procedures at this time. And there are some, I think, significant omissions, and patients should be aware that it's not the same coverage. I think the other thing that we all need to be aware of is that the evolution of the CDCP is uncertain. We don't have a written agreement. The minister clearly has reserved the right to modify or change the plan as he sees fit. So politics being what it is, we could see some substantial changes to the plan. And it would be unfortunate if a patient gave up their dental plan and went to the CDCP only to find that it was changed in a way that was not beneficial to them. And my sixth point is there is some evidence that some practices are inclined to max out the annual limits. Be careful about doing that. What we want to make sure is that patients really do feel that they're being looked after and the care that they're getting is absolutely necessary. And if they bump into a limit on their third-party plan and they do not see a limit on the CDCP, that would be an incentive for them to switch to the CDCP. The other point I would make here is make sure that you're customizing preventive care to the actual needs of the patients. One of the things that I think I've tried to impress upon the profession in the past is that we should try and get away from the boogeyman that every hygiene appointment has to be for an hour. Nobody believes that a 55-year-old smoker with poor home care needs exactly the same amount of time as a 15-year-old teenager, and yet that's what happens. And one of the things that we're going to see in the future is limitation on the availability of hygienists. So when I say customized preventive care, there are people that need half an hour. Let's give them half an hour, and people that need an hour and a half, let's give them the hour and a half. And I think for many cases, when a patient needs a procedure that would not be covered by CDCP, you might want to make a note of that for the patient so that they understand the benefits of their third-party insurance. I think this is particularly important over the next 18 months. The writ for general election has to be dropped before October, late October of 25. And so in that time, there may be all sorts of things that could or could not happen to the CDCP. And I think it's important for us to be vigilant and to try and convince the public that the third-party insurance programs have worked extremely well. And it would be beneficial if they would simply be extended to the whole population. And I think I'm coming to my final and last. Stop fighting when you have won. The reason why I put this in is that I do not think we want to see the remedial fees any higher than they are right now. And the reason for that is that I'm afraid that some people would decide not to balance bill. And I don't think that's in the long run interest for the profession. And I think that the other thing that I think the profession should be aware of is that because balance billing is so crucial, we should be prepared to fight for it if government threatens to take that right away. Thank you very much and have a good evening.
Thank you, Dr. House. I'll now turn the presentation over to Mr. Reid, who will give us a closer look at the potential impact of the CDCP for the average practice.
Good evening, everyone. I'm glad to have this opportunity to speak to you. Well, by its intended design, the CDCP should increase access to care across the country. Now, this will boost patient demand, but the natural question is, by how much? Hopefully we can help with that. I'd like to talk about the new potential patients. This chart can help us to predict how patient behavior might change. This is from a CD Howe report. The source is the Canadian Community Health Survey from 2014. I looked at more recent CCH data from 2021, and the results are very similar. Now, to quickly describe this chart for you, let's look at the bottom right to left. You have household income deciles. From bottom to top is the probability of visiting a dentist in a previous 12-month period. Now, circled in blue here, this represents the uninsured part of the population who also happen to be in the lower half of the income distribution. This is your CDCP crowd. They have about a 40% chance of going to the dentist in a 12-month period. Now, if you give the same group dental insurance, you're now moving from the blue circle up to the red circle. And now the probability of visiting the dentist shoots up to about 75%. This is what should cause an increase in demand for your services. Well, as you can see in the first bullet point here on this slide, we give it away right away. Our prediction is a 14% increase in patient flow. And you might ask, what do we mean by unique patients? Well, that is simply if George goes to the dentist 3 times in a year, we count him once. Now, as long as CDCP patients have similar dental spend needs as the rest, this should translate into approximately 14% more hours worked that is required by the profession. And that's required by both dentists and hygienists. Now, the remedial work, in our view, could easily be serviced. Let's look back 15 years ago. The average dentist was working just over 1,500 hours on average. When I look at the 2023 data, I'm seeing something close to 1,350. So there's lots of room. We believe there's excess capacity for all of the dental appointments to be met. But the other side of the coin is that you would need 14% more hygiene hours as well. We are skeptical that that can be accomplished, given our view that there's a hygiene shortage now and that it's going to persist for quite a long time, up to a decade. Finally, if this patient flow increase occurs, we would estimate that you now have 1/4 of all your patients would be on CDCP patients. And then the very last figure on this slide, the average practice would see about 11% of their existing patients converting to CDCP patients. Now, all of this is assuming that there is no erosion of third-party insurance plans. I'd like to talk about that next. So there's danger of third-party erosion. Now, that is not as significant as it was before balanced billing was secured, but it's still an issue. In our view, the eventual outcome is that there will be erosion of the third-party plans. And what do we mean by erosion? Just to clarify, that is when someone drops their private insurance to go onto the CDCP. So from bullet point 2, you can see under the 70K threshold, there's actually more individuals who could drop their private insurance to go onto the CDCP than there are eligible in the first place. And in the bottom box here, it's just an illustration. So if 1/4 of all of those who could drop their insurance do, then you would have 1/3 of all patients being CDCP patients, as opposed to 1/4. This would be a danger for the federal budget and the affordability of this program in general. One danger would be if Health Canada's response to the costlier program is to freeze the fees in the CDCP schedule year over year. Well, the key point here is that if you do balance bill, it's a problem, but mostly for the government, not for your practice, at least in the short run. However, if you do not elect to balance bill, then this issue of erosion would slowly eat away at your revenue as individuals drop their insurance, go onto the CDCP, and are now charged at lower fees. So let's talk about fees. Now, this has a lot of numbers on this slide to go over, so let's just take it slow. This is an example of what a practice might look like, a typical practice, with and without the existence of the CDCP. So if you focus your attention to the left of the black bar, you have a practice if there was no CDCP. So most of your patients are cash private insurance patients, and they are paying close to both ODA suggested fee guide. You have 5% of your patients on provincial programs, and the compensation relative to the fee guide is only 40%. And there's another 1.5% on the existing federal programs. To the right of the black bar, you now have your practice in 2025 with the CDCP, and you can see that 25% of your patients are federal program patients now. Now, just take a step back. When we first looked at this program, when the details first came out, we thought that it had a net negative impact. But once you put all these numbers down and realize that the federal program can jump in and save you from the abysmal provincial programs, it doesn't turn out so bad. The impact of just 5% of patients going from being reimbursed at 40% of the fee guide to 84% of the fee guide is quite powerful. Now, this is an example where the average fee charged to your patient does not change much, and this is with no balance billing or coordination of benefits between the federal and provincial program. Moving on to the next slide, we add if there was 100% balance billing. The only change between the slides really is that now your 25% of CDCP patients are now being reimbursed at nearly full fees, and your average fee is now increasing 3.5%. Now, I'd like to go over revenue changes for the average practice now. We have discussed patients, fees, you put it together, you get the revenues. Now, keep in mind, this is for the average practice, not any practice in particular. There will be enormous variation in how this program impacts practices across Ontario. And I'd like a quick disclaimer here. This is not a forecast from 2024 to 2025. This is simply a comparison of practices in 2025 with and without the existence of the CDCP. For the first two cases, we're going to go with very optimistic assumptions, which is number one, there's no erosion of private insurance, and number two, all of the new appointment demand is serviced. So patient sittings are increasing 14.4%. Now for the first two examples, it's just to show the impact of balance billing. So this is with no balance billing. You work more hours, you make more money, and your net income increases, but your net income per hour actually goes down a little bit. If you add in balance billing to the equation, we just moved forward a slide, the direct impact is a 10% boost to your net income. You can now see the average fee charged is 3.5% higher. Okay, that's enough of being overly optimistic. Next, we go with some more conservative assumptions. So this is our realistic case for the medium-term future, let's call it. This is not a long-term forecast. As Dr. House mentioned in his presentation, he's not quite sure of the long-term sustainability of all of this. So let's call this a short to medium-term forecast. 1 in 5 individuals who do drop their private insurance and go on to the CDCP. We have 3 in 4 dentists who are balance billing. 0.3 is a big one, which is that only half of the new hygiene appointments demanded are supplied. And we assume that all of the dental appointments are serviced. So despite more conservative assumptions now in this scenario, the average practice should see some solid improvement. It's worth mentioning, in this realistic case, net income per hour is, again, relatively unchanged. To have an increase in your net income, you have to work more hours. However, if you took balance billing back down to 0%, if it was not permitted, the net income per hour would decrease by about 8%. Now, this is the impact, our forecast for the average practice, but there is no average practice. Let's not forget that. So let's move on to something more interesting. I'd like to entertain 2 edge cases, the best case and the worst case. They've been constructed so it's representing maybe 3 or 4 practices on either end of the spectrum. Well, actually, there is a worst case, and I don't have a slide for it, but it's simply that if nearly all the dentists are signing up and a few don't, well, those practices that don't, could see 10 to 20% of their patients simply leave over the course of, who knows, maybe a year or 2. And they would go down the street to the dentists in town who are signed up for the CDCP. But what is the worst case scenario if you do sign up? Well, this would be a practice that previously had no provincial program patients. This is a practice that doesn't want to work more hours. They're at full capacity. If you're located in a lower income region, perhaps more of your existing patients convert to the CDCP. Recall earlier in my presentation, the average practice, we predicted 11% of patients would convert. Well, this practice would have more than 20% of their patients converting. This practice does not balance bill. And finally, they're relatively inefficient with an expense to gross 0.7, or for the average practice, it's 0.6. The result is simply that the average fee charged is 3% lower, but that declines net income by 10%. Recall the patient sittings is not changing because this practice did not want to accept more patients. But the great news is, if this practice changed their mind and decided to balance bill, all of these numbers go to 0. Well, that's not so bad for a worst case scenario. So what is the best case scenario? So this practice has 20% of their patients who are provincial program patients, which is, by the way, not that uncommon. They are willing to expand their patient base. Let's say their patient settings grow 20%. They're located in a low-income region. They do balance bill, and again, they're relatively inefficient. The benefits of the CDCP program are immense for this group. Average collections per patient is increasing by 15%. Even if this practice did not balance bill, their net income would still be 50% higher. It's quite dramatic. Well, for those of you who have read Dr. House's report to the professions over the years, you would have seen him writing frequently about the falling population dentist ratio. This is not exactly that. This is the active patient per dentist ratio. In other words, the number of people going to the dentist in a given year per dentist. Now, in the 1990s, you can see this ratio was around 1,400, and it nearly fell below 1,000 in 2019. That's about a 35% decline in your patient pool per dentist. However, in 2020, this ratio stopped going down. The number of dentists stopped outgrowing the general population. And with the CDCP set to boost utilization rate, you will have more active patients per dentist. It's like going back in time to the conditions that were present around 2009. As long as this program is a success and manages to get more people into the offices, this is a good reason to be optimistic. And that's the end of my presentation. Thank you very much for your time, and have a good night.
Thank you, Mr. Reid, for that very informative presentation. So we'll now move to the live portion of the webinar where Dr. House and Mr. Reid will take your questions. Again, just to recap those instructions that I provided at the beginning of the webinar, you can submit your questions through the Q&A box that's located to the top right of the video window, and you must exit the full screen to view and access that Q&A box. So to do so, make sure you hit the escape key on your keyboard anytime that you're in the full screen view. So I just want to talk about the number of attendees we have tonight. It's been a wonderful turnout. We have 1,200 attendees who've registered for today's webinar. It's been very impressive. And as I'm sure you can appreciate, just because of that, we have a very high volume of questions. And we only have about 37 minutes left. So we're going to try to get to as many of those questions as we can. But we're certainly not going to be able to get to them all. So for that, I apologize in advance. So here's how we're going to do this. We'll answer as many questions as we can by trying to get to as many different questioners and topics as possible. So if you're submitting multiple questions, please know that to be fair to as many people as possible, we're only going to select one of those questions that you submitted. And we'll also try to vary the topic so that we're not asking the same question repetitively. That's just to cover as much ground as we possibly can in our limited time. If there's any questions that you've submitted that we can't get tonight, please know we are collecting them and we will use them. What we're going to do is take those questions back and we'll use them to inform future ODA communications that we do to members on this topic, whether that's future webinars, email updates in the composite, messages from the president, or information on our website. So your questions are still valuable. Please continue to submit them and we'll get to as many as we possibly can today. So we're now going to move to the first question, and we're going to start here with Dr. House. So Dr. House, are there any insights that you can give in relation to the impact of the coordination of benefits and how that will have an impact on dental practices? For example, Healthy Smiles Ontario or the ODSP program?
I think this is going to be quite straightforward. As I understand it right now, the federal government, it's proposed the federal government would be the payer of first resort. That means almost automatically you're going to go from fees that are around 35% of the ODA guide to something that's more in the order of 84%. Big leap. So that's a very positive thing. And under discussion is the possibility that the provincial plans will be the top up to balance bill. I don't think that's confirmed yet, but that is under discussion.
Thank you so much. Okay, the next question is about practice valuations. So the question is, how will CDCP impact future practice valuations in a general sense? And in particular, the questioner is asking if insurance carriers were to drop their, well, they're saying their fee guides, but I presume they mean the amount that they'll cover related to the suggested fee guide. What would be the impact on practice values?
Well, there are a number of ways of looking at this, but let me start by saying I don't think I know, because practice evaluations are dependent on so many other things, like the interest rate, for example. But any climate that creates a greater uncertainty is going to diminish the value of an asset. And therefore, all other things being equal, just about the fact that we're now in a very volatile situation, waiting for this to evolve into its final form, it should have a negative impact on the practice evaluations. The other thing that's going to happen, of course, is because you've got a whole bunch of new people coming in, it's going to become more feasible to start a practice from scratch, particularly in the poorer areas where you'd have predominantly CDC patients.
Okay. There's a number of questions that we have here that I'll say are not necessarily economics related. They're questions about the ODA, some of the activity that the ODA has participated in. As I said at the front end of the presentation, I think that those are the types of questions the ODA might be able to answer directly. So what we'll do is we'll send those back. We'll try to communicate that out to all members. But I would say if you have questions about how the program itself works from a technical perspective in terms of how the government has designed the program, what the ODA has been doing about the program, I'd encourage you to email those into the ODA, and we will provide answers to you directly. We'll have those email addresses up at the very end of the presentation. So I'm just going to go to the next question. It's a little bit longer, and we'll ask Dr. House this one as well. So similar to the previous question, the questioner is saying they realize that the statistics have shown a couple of what they are calling questionable requirements, namely that balance billing must be able to remain in continuity, and that the program should not expand beyond what is currently suggested by the government as the 9 million vulnerable Canadians. The questioner is saying that if balance billing is taken away, as it was with the doctors in the 1980s, and de-insurance happens, as they believe would be sensibly expected by prudent large businesses and corporations that are discontinuing their private dental benefits, socialization of dentistry in Canada is inevitable. They're citing a statistics website. I don't know the source of this, so this is from the questioner, not from us. That 85% of the Canadian population earns a household income of less than $90,000. So the question is, how would this affect the valuation of dental practices? Would they be similar to medical practices in terms of their lack of value?
Well, this is a question very similar to the last one in terms of practice evaluation. And again, I'm going to say it's going to depend on a lot of different factors. Ultimately, what determines the value of a practice is supply and demand. And on the demand side, we've got two factors here. One, and that is an increase in the number of patients. That should increase the value of a practice. On the other hand, we have uncertainty about the fees that are actually going to be available, and that uncertainty will decrease the value of the practice. So how this is going to work out over the next decade, for example, I think is problematical. If we had solid data on what was going to happen to the fees under the CDCP, or we had solid data on how population growth and the growth in the number of dentists was going to evolve, we probably could come up with some kind of an answer, but those are all mysteries. In the past year, the Canadian population grew by almost around about 3.5%, which is unheard of. If that continues, and if the ratio of dentists in that intake falls, then it's going to be a lot easier to start your own practice, and the goodwill value of a practice will fall. Will that happen? I really don't know. And I think anybody that's trying to make a decision on whether now is the right time to sell a practice, God help you. I'm not sure I'm going to be able to.
Thanks for that. So I think the next question, we'll try with Mr. Reid for this one. It's asking some questions about the numbers and scenarios, and in particular, it looks like what's been presented is more specifically for the general dentist. So can you provide any insights? And I don't know, Mr. Reid or perhaps Dr. House can answer this. How do the numbers change with specialists? And in particular, the questioner is asking about pediatric dentists, but I'd suggest we answered about various specialties that might be covered under the CDCP.
Well, I'd like to begin, Ron, just by saying if it's a pediatric practice, we know that pediatric practices have significantly more provincial program patients. So as you could recall from my slide, that's obviously going to be the specialty I think that benefits the most, because that's who is benefiting the most from this program.
I would agree with that. Yeah.
And maybe I'll probe a little bit. So in terms of some of the other specialties, it sounds like pediatrics could benefit the most. Do you see any particular specialties that either might benefit the least or may have the most to be concerned about compared to other specialties when it comes to the CDCP?
Well, I'll take that one again quickly here, Ron. My only comment there is looking at the fee schedule, there are no, the procedures that periodontists are performing are not in the ODSP fee schedule. So obviously they're going to benefit the least. As far as all of the other specialties, it's very difficult to say, I think. Those two, to me, are the most obvious, that there's going to be a positive and absolutely no impact. Ron, anything to add?
Well, I think probably the one group that's going to be hurt the most is likely to be dental anesthesiology, because their fees right now are an amalgam of other specialty fees, and basically, as I understand it, most of their remedial fees are going to be the same as GPs. So they may have a problem.
Yeah. So I'm going to switch gears here a little bit. The next question is about dental benefits. So what, in your estimation, is there to stop companies from canceling employee dental benefits and just sending everybody on to the CDCP?
Well, I think if you think about what I showed for those with plans and incomes over 70K, those above 70K to 80K, and certainly below 80 to 90K, they're far better off staying with their plans. And the answer to that question, I think, is you've got to remember how these plans came about in the first place. They were demanded by employees. They weren't something employers were happy to give away. It was something that was negotiated in the wage package. And I think that in most cases, people are going to want to insist on that, particularly if we could demonstrate, as a couple of my slides did, it'd be far more expensive for these people to move on to the CDCP. And that's why I see this as a very unstable situation right now, is that it's a joke for those between 70 and 80K, or sorry, between 80 and 90K, to imagine they're getting something, quote, free dental care. It's not. It's going to cost them 60% of whatever or 66% of whatever the ODA bill would have been if we balance bill. So there's going to be a strong demand to maintain those. What I can imagine happening is that employers might say, okay, look, what we're going to do is give you flex benefits. And for those in the lower income groups that would want to switch, which will certainly be those below 70K, they could give up their dental plan and go to the CDCP and maybe take some other benefit like additional holidays, that type of thing. Again, we really don't know how this plan is going to evolve in the final stages, so there's a lot of uncertainty here, but I don't see a significant erosion as long as we have the right to balance bill.
Okay, thank you. So there's another question here it is about balance billing. Maybe I'll send this over to Dr. House again. There's an assumption by the questioner that given the Canada Health Act, it's only a matter of time before balance billing will disappear, as the government has repeatedly said that the CDCP is supposed to be free for the public. So maybe I'll just add a comment before I hand it over to you. I think it's important for us to distinguish between what the government in terms of Health Canada and the Minister of Health is saying versus what might be being said by elected officials. So the language, we haven't at the ODA been satisfied with the language that's come out about this program, and it has created a lot of public confusion about whether it's free or not. It certainly is not a free dental program, and we are working to get that message out to the public. But maybe, Ron, you could speak specifically to the balance billing question, and questions about where you see this going given some of the rules under the Canada Health Act.
Well, of course, this does not fall under the Canada Health Act. And that in itself may eventually prove to be a problem or a benefit. We again don't know. We don't have, as I understand it, at this stage, a written agreement. There's nothing down in black and white that says this is what the government's going to commit to do. And so, again, I'm going to say we're in a very evolutionary situation. What I do think is important is that the profession create the appearance that balanced billing is something that it would definitely fight for, because if they mandate fees like they have for the physicians, for example, we're taking a really successful dental care delivery system now that reaches out to probably something in the order of 80 or 85% of Canadians. This was not a plan that was designed to really address those that are in need, for example, those in long-term care homes and that sort of thing. There's still a lot of gaps in that sense. This was a plan that was cobbled together to satisfy a political need. We all recognize that. And when that political need disappears, then I think we can expect changes. Will we go the route of the physicians? Obviously, there's going to be a lot of sentiment that feels that, yes, we should, as a nation, combine medical care, dental care, and any other aspect really of healthcare. It all falls under the same umbrella. But what we're witnessing right now is huge problems with the medical hospital physician care in this country. And governments may or may not have learned the lesson that if you're abusive, you drive physicians away. And that's created problems. So are the people in Ottawa and Queen's Park really looking at what's happened over the last decade to the Canada healthcare system? If they have, I think what they would do is move very gingerly in that direction. And in fact, I would recommend that we take the minister at his word. When he said, well, this is supposed to be a dental plan, just like any other dental plan, so I don't know what dentists are complaining about. My suggestion would be, well, why not just pay a premium so everybody can get a dental plan and they can go to London Life or whoever they choose, as long as they cover the basic benefits that were to be covered under CDCP. I think part of the issue right now is that we have to have a vision of where we want to push government. And I'm not sure that that exists across the country yet.
Okay. So the next question, maybe I'll start with Mr. Reid again on this one. What the questioner is asking, why is it an income loss if we are upfront telling patients that the CDCP is not going to cover everything?
Well, that was Ron's slide, so I'm gonna let Ron answer that one.
Dr. Huss?
I stopped paying attention when you said Mr. Reid.
Okay, I'll repeat the question. So the question is, why is it an income loss if we're upfront telling patients that the CDCP is not going to cover everything?
Why is it an income loss?
Yes, that's the question.
I don't think I understand the question.
Yeah, I think you were suggesting in the presentation that it won't be an income loss if you balance bill. So
I see. Yeah, all right. No, it won't be, because I mean at that point you're charging your regular suggested fees. You're not taking a hit. If you don't balance bill, you take the hit. Again, I'm a little confused by the question, because I think it's fairly obvious that there will be income loss if you just charge the CDCP fees.
Yeah, and I think that's probably what the question is getting at. So that's helpful. And to the questioner, feel free to pop the question back in the chat if you feel that answer didn't.
Yeah, or if anybody is unsatisfied with the answers now, they can always drop us an email and we can have a phone call about these things too.
For sure. No, I appreciate that. That's great. Okay, so we'll go to the next one. Could you please explain the difference between balance billing and copay? Who wants to take that one?
Yeah, I'll take that. Or Graeme, you get paid just as much as I do, so we should share these things. Copay is something that's mandated under the plan. In other words, if you look at a third-party plan, it will say the plan is going to pay 80% of the fee, and it'll list the fee. Let's say the fee is $100, so it'll pay $80. And the dentist has an obligation to charge the patient $20. That's the copay. Now, what is happening under those people that are between the or above the 70K is that they will get a portion of the basic fee paid, and then they will have a copay. And then if we balance bill, that will be in addition to that, because the copay would only take you up to the level of the CDCP fees, which for, let's say, restorative procedures is that 81% of the ODA suggested fee. So that person, when they're looking at a 40% copay, and then they're looking at an additional chunk on top of that, they wind up paying almost half the bill between the combination of copay and balance billing. So copay, if you like, is mandated. In other words, the dentist is supposed to charge it. And presumably in third-party situations, the idea of copay is to put a brake on demand for things that maybe are not really desired by the patient, and the patient would decline because they have a copay.
Okay, helpful. So this is an interesting question. How will the government know what dentists are billing, and most importantly, if they're balance billing or not? I don't know. Dr. House, you want to try that one? It's an interesting question.
And I'm just guessing here, so we better be very careful about what I have to say. I would imagine that most of the billing is going to go through the CDA net, and the invoices, if you like, that are passed on will show the total charges to the patient. I don't know that that will be the case, but I suspect that the government will want to know. And if they don't know that way, they're going to hear from patients pretty darn quickly. I think that a lot of patients are going to go into their dentist's office and think everything's taken care of. And then when they're hit with the copay, and you can point to the black and white that says, yes, you're responsible for a copay, it's going to be more difficult to point to something that says, yes, you can charge the balance bill. The patients are going to be on the phone to Ottawa pretty darn quickly. So they will know what's going on. The other thing, too, is, we're talking about the federal government here. Although I understand that in Ottawa, various departments are not to have access to income tax information. I've had an experience at the negotiating table where a provincial government provided tax information that could have only come from Ottawa. So, the Chinese wall here gets breached in a lot of different ways. I think we have to assume that the government's going to know exactly what's going on. They're going to see what procedures are being provided. They're going to know what their bill is, what their responsibility is, and they're going to hear from patients. So I don't think that we're in an environment where we can imagine that we could go ahead and balance bill and government won't know about it. They will. And they should. I mean, I think we should make it clear that balance billing is part of what is going to make this dental plan work at this stage.
Absolutely. Okay. Our next question, and it's in the same vein. Does the failure to balance bill undermine the credibility of the ODA's suggested fee guide and the effort that goes into determining what the fee guide is? And I don't want to lead your question, Dr. House, but this might be a good time to plug the economic survey. So I'll send that over to you.
Well, yes, it does. A lot of practices now have expense gross ratios well in excess of 0.6. That is the average, but we've got a very broad, very large standard deviation on that. And so there are a lot of practices that are up at 0.7 and even beyond that. What we do know is that if you expect a dentist to go through the kind of training they do, work the hours they do, and that sort of thing, and you expect to be able to pay them $45,000 a year, well, that's not the world that I see in the data. And when you look at the ODA fees, we did an international comparison with European countries, and we're about average for all the European countries. We actually did this by having a set of procedures using the same set of procedures that were used in the European study. And so the ODA fees are very reasonable by international standards. They provide an adequate living for the average dentist. There are some dentists, of course, that have multiple practices and have lots of associates that are making a lot of money. There's no denying that. But we've also got to recognize that this is an area where entrepreneurial effort is required, and there's a sizable amount of invested capital. I mean, it's very interesting that the first few questions were on practice evaluation, because people are obviously looking at a major asset. And so, yeah, no, the fee guide, I think, is perfectly reasonable. Historically, because we were trying to grow the active patient population, because of the number of dentists was growing so rapidly, our fee guide was just about the same as the rate of inflation for almost 2 decades, and maybe a little bit ahead of it in some years. Some years we didn't get the inflation rate just quite right. We fell behind. We had to do a little bit of catch up, and then of course we hit COVID, and we had to recognize that new constraints were being placed on the way in which people could practice dentistry. There were new requirements in terms of the technology involved in the office, IPAC and that sort of thing, and an acceleration in wage rates that a lot of dentists were facing. And we saw very sizable increases over the last few years. Now, if the Canadian inflation rate starts to come back down, and if the Canadian population grows the way I expect it's going to grow, we're probably going to be able to have growing incomes and relatively modest fee increases, so that we can attract more and more people into dentistry. You've got to remember that dentistry declared that it was an essential service. And if essential service means anything, it means that everybody has to be entitled to get it. And so I don't think that's something we can back away from. We want to make dentistry accessible to as large a part of the population as we can. But on the other hand, we have to support the very high overhead costs of modern dentistry now.
Okay, our next question, I think we'll go to Mr. Reid for this one. There's an assumption that the number of patients will give up their insurance, and the question is whether we can explain this assumption. The questioner is saying that they think that employers now have to report whether they offer a dental plan on T4s, and people won't qualify for the CDCP if their employer offers an annual plan. And actually, I can confirm that's correct. But can you walk through again how you estimated people moving off of private insurance? How was that estimate arrived at?
Well, that was more of a medium to long-term estimate, so it's not going to happen overnight. But this, as Ron showed, he had earlier slides where the incentive for those who are under 70K have a strong incentive to do so. So yeah, maybe the large businesses, the large corporations that have a lot of people under coverage are not going to budge, and the government has asked them not to budge. But in the medium to long term, when the incentive is there, things tend to shift or move as slowly as you would say. And also smaller businesses have a much stronger incentive to simply drop their insurance plans. And I understand that there's limitations. I believe like a year, if you had insurance last year, you're not eligible for another year or something like that. But again, this is more of a longer term prediction. Ron, do you have any comment as well?
My view is that the way the eligibility is supposed to work is unworkable. And the reason why I say that is that it's going to be very hard to track people who are in need based on last year's income. I mean, it's quite clear that somebody could have had a good income the previous year, fallen on hard times. They have a need for dental services today, and they can't wait a year for their eligibility to be approved. From my point of view, this is not a very good delivery system. We should be able to create a system where if a person today falls below the income level and not based on last year's tax returns, and they need care, they should be able to get it. So when I talk about this as being a plan that's in evolution, I'm going to take you back to the fact nothing's on paper right now that's chiseled in stone. So I think these are questions that are going to be answered over the next 4 or 5 years, or maybe even sooner. You know, the day the Liberals drop the writ for general election is the day they no longer need NDP support. And in an election environment, what are the Liberals likely to promise the public at that time? I have no idea. I've not been party to them. I don't know if the government itself knows the answer to that question. But I think if we think that there's anything permanent about what we're seeing today, we're probably making a mistake. I think that the way the profession to look at this is that we want to try and make this work. It is workable if there's certain changes made to it. And we would like to see it ultimately in writing, so we have some security. But I think we recognize we need to have a plan. We need to know what we want. We need to be able to tell government this is what we want. And as in any negotiation, at some point, you're going to have to draw a line in the sand and say, you know, just you don't cross this line, that kind of thing. So there's so much that's going on here because this is going to be a push-pull between, you know, what the public wants, what the profession wants, what government wants. The fact of the matter is that this is going to turn out to be a far more expensive program than the government ever imagined if they follow through with their plans, or it's going to be a disaster for dentistry. And so I wouldn't want to lay any bets on where this plan will be in 5 years' time.
Yeah, I don't think it would be smart for any of us to make those types of bets. Okay, the next question here is, what do you think about not accepting new patients onto this program, but keeping the existing patient who will change this program with balance billing? So I think the idea behind this question is, you know, accepting new patients versus treating your current patient of records. And maybe I'll just quickly let everybody know that the ODA has consulted with expert advisors, including legal counsel. And we have an answer for that question up on our website. So, you know, I'd encourage everybody to visit the website and it will take you through exactly how you make those decisions. Doesn't speak to the economic piece, which maybe Dr. House wants to speak to, but in terms of what you are and aren't allowed to do, that information is available on the ODA's website. So maybe I'll turn it over to Dr. House to talk about the theoretical behind that question.
There's not much theory here. The thing is that there's probably 30 to 40% of the practices in the province right now would like to have more patients, and more patients would improve your income. I am an economist. I believe that a lot of us are motivated by the almighty dollar. Whether that's a good thing or a bad thing, I think is a whole other question. But if you want to improve your income, of course, go ahead and accept these patients. The legal ramification about whether you'll be required in the future to continue to treat these patients if the remuneration changes, I guess, is something you'd have to worry about. But under normal common law, if somebody isn't prepared to pay the bill, you're not obliged to provide continuing care or periodic care. You are providing continuing care if it's an ongoing case. But if somebody disappears for 6 months and comes back with a new problem, then I don't believe that you would have a problem.
Okay, we have about 6 minutes to go, so we'll take 3 or 4 more questions. I'm going to move to the next one. Dr. House, you've alluded to this during your presentation, but if there's anything additional that you want to add, the question is, do you anticipate that private plans will start to cover dental care at the level of the CDCP benefits grid?
No, I don't think that's going to happen. I don't think that the unions would stand for it. I don't think that management level people want to see that happen. You've got to remember that there's a strong vested interest. And in some plans, they wouldn't be able to do that because there's a written agreement. I have a dental plan from the university, and it's pretty much clear what they have to pay. So no, I don't think that's not a fear I would have.
Okay. Next question. You've highlighted the importance of balance billing throughout this presentation. Our question is, What percentage of dentists do you think will choose to survive without balance billing? And I think there's a question here that says, how do we maintain the unified vision in a competitive market? So if you don't mind, I'm going to start just by reiterating that the ODA is here to inform members, but again, our role is not to tell members what to do. We very clearly have to provide information and education to help you all make an informed decision. But what I will share is what we're hearing from members. I think that's important information for everybody to know. We did do a pulse survey. Hopefully you all participated in this. This was a couple of weeks ago where we asked members their most recent opinions on the CDCP. And 75% of respondents said that they would balance bill patients when they participate. And this was actually an increase from 60% in February. So that just gives you a sense of where the membership was feeling about things just a week or two ago when we did that survey. But again, it is an individual decision. So I will send the actual question itself over to Dr. Hudson.
My view is that this will be an evolutionary thing. Again, there are people that I think for altruistic reasons, and God bless them, would like to think that they don't need to balance bill. But I think they'll quickly realize that the economics of the practice, if they're going to have very many of these people in the practice, and it's imperative that they do balance bill. And so I would think virtually everybody, when the dust settles, will be balance billing. There won't be any particular merit to not balance billing if you see that all your neighbors around you are balance billing. And you'll want to keep it competitive. And I think a lot of people are going to come to the realization that if they don't balance bill, the signal they're sending government is that these fees are perfectly adequate. If they think those fees are perfectly adequate, we're not on the same planet. I mean, we've tried to carve these fees down to be reasonable, to provide access to care, and to support the overheads of a dental practice. You can't cut these, we're talking about cutting the fees for remedial services by 20%. That's a 50% reduction in the net income for a dentist on those procedures. That's arithmetic, that's not theory. And any one of you can sit down and do that calculation. And I can't believe that those that do that calculation are going to feel that they don't need to balance bill. Just, it's not in the cards.
Okay, so the next question. And this speaks to the administrative burden. This is a really important question, one that we've been grappling with for a while and talking about an awful lot at the ODA. So the questioner is talking about the complexity of how the dentist is required to inform the patient about their fees with balance billing. And the questioner is saying that this is beyond the ability of most office administrative teams, especially post-COVID. The cost of this management does not seem to be considered in this discussion. So how realistic is charging dental offices and their administrative teams with being able to explain all of this complexity to their patients?
Well, I think that you probably could have a very simple one-page example. The government's going to pay, my fee is $100. The government's going to pay $80. Because you're in this tax bracket, you're going to have a copay of this amount, which I'm required to recover from you. And my balance billing for my regular customary fees is this amount. And I think most people, if they were sat down and they read that and you asked them to sign off on it, then I think you can go ahead and do it. The important thing is that people are informed before the procedure starts about what is going to happen. And I don't think it's that complex. I think that because we've heard so much, it sounds complex, but in a way, it's really quite simple. It takes 3 numbers across the top of a page to explain it.
Yeah. Could I just add something? It may be difficult to explain, but this is a brand new program. Give it 6 months. Your staff will understand it better and better, and the explanation will get easier and easier. And secondly, what matters is it relatively more or difficult or easier than the existing insurance plans out there? There's some insurance plans out there that are not exactly simple. There's some confusing plans. So dentists have been dealing with this for a long time. So the question is whether it's significantly more complicated to explain than the existing plans.
Marcus, if I could come back on the
Sure.
administrative burden, this is real. And just as we saw COVID added cost to dental practice and IPAC added cost to dental practice, I think the kind of verification and the pre-authorization and all that kind of stuff that has to go on, large practices are going to probably find that they've got to put another person on the front desk. So, one of the things the government needs to understand is that they're creating a bit of a bureaucratic nightmare for the profession. And if you think there are 6,000 practices out there and every one of them is going to have to hire another person, well, anybody can do the arithmetic. By the time you provide the overheads and all the rest of it, that's going to add to the cost of care. And what Graeme and I are going to wind up doing is saying, okay, this is going to be factored into the overhead cost of the practice. And in the fee formula, that's going to be recovered. So does government really want to do this? I mean, I think the thing that I've seen, particularly with the IPAC and that kind of thing, is that public servants seem to have absolutely no understanding of the bureaucratic or the cost of increased bureaucracy. And this is something I think the ODA is quite right in hammering home. This is a major point because it's going to add unnecessarily to costs.
Okay, it's now 8:32, so I know we're a bit over time. There are many great questions. For those people we didn't get to your question, I apologize. So I'm gonna wrap up with this question because we haven't really talked about it too much, although you did in your presentation, Dr. House. So the question is, do you think associate compensation models will change? Meaning they're being paid less than 40% of the industry standard to compensate for the loss of income. That's what the questioner is suggesting. The questioner suggests in the United States, associate dentists are paid 30 to 33% of adjusted production. So maybe if you have any comments there, that'll be a good way to close off for today.
Well, one of the things that my office has decided we never want to get involved in is a dispute between associates and principals or issues of gender compensation or something like that, because as consultants, wouldn't matter what we said, we couldn't win. My answer is that if you balance bill, then there should be no need to change the compensation formulas. If you don't, then the compensation formulas right now are not viable because it means that if there's no change and you just say, well, we're going to work off the CDCP revenues, then both the principal and the associate take a hit. If you try and put the whole burden on the associate incomes are going to fall dramatically. And at that point, the associates are going to have a huge incentive to go out and create their own practices and balance bill. That was one of the reasons why I said I think balanced billing's absolutely inevitable. And when you think right now, about 50% of the practice nearly is associates. Well, right there's 50% of the dentists in this province are going to demand that they balance bill.
Okay, I think I'll make one last comment. There is a question here that's more of a comment than a question. Somebody who's in the know, and you know who you are, reminded me through the Q&As that we should let everybody know there were a lot of questions tonight about practice values, and we should let everyone know that the ODA will be working on some upcoming sessions, particularly on practice valuations with experts, including somebody who's in attendance tonight, but I won't spoil the fun. We'll let you know very soon via email. With that, I'm going to close off the presentation. I really want to thank everybody for their great questions tonight. As I said, we couldn't get to them all, but if you have any questions that we couldn't answer this evening and you really want to send them in, the email addresses are up on the screen. Here's where you can contact the ODA. And there's two different email addresses here. So your economics of practice and your billing questions, you can go to our practice advisory services team. This is the team that works with Dr. House and Mr. Reid and the team at Oeconomicae, as well as our economics advisory committee. So they can answer a lot of your questions about billing questions, coding, et cetera, and the general economics of practice questions. And the ones they can't, they'll certainly pass on to our presenters. If you have questions about what the ODA is doing on the advocacy side or dealings with the government, specifics about how the program runs, there is an awful lot of information on our website at www.oda.ca. I encourage you to go and visit the FAQs for dentists. There are two FAQs, one for patients and one for dentists. and they're both available on that website. But you're also welcome to send your questions in to advocacy@oda.ca, and that's the other address up on your screen. And we'll look to get back to you as soon as we possibly can. Again, we've collected all the questions today, and we'll use them to inform future sessions. And in case you missed it at the beginning, I know some people have been asking, yes, a recording of this presentation will be made available in the coming days, and we'll notify members by email about that when it's ready. So just a final thank you to Dr. House and Mr. Reid for your generosity with your time this evening and for being with us this evening. I hope everybody has a great night, and I hope that you found this a very valuable session. Thank you so much from the ODA, and have a great evening.